This session, it's a kind of continuation from the yesterday session, a subject of primary healthcare improvement, optimization, and changing towards value. And our first speaker, Ms. Sylvie Ackaert, will give us a presentation concerning primary healthcare in Flanders. The floor is yours.
Oh, already, okay. Thank you very much. And good morning, everyone, in the beautiful Queen Elizabeth Hall, which gives me a little bit of pressure, but I'll do my utterly best to give you a quite exciting presentation. I think my presentation will be a little bit different from the others. It will be more of an overview, a helicopter view of the needs of primary care in Flanders, because I am from the University of Applied Science of Arteveldehogeschool in Ghent, and we performed a 360-degree scan or a broad needs assessment in primary care in Flanders. With the emphasis on we, I didn't do this work alone. I had two colleagues by my side, and one of them is here supporting me. So thank you very much, Lotte van Este, which is an occupational therapist, and also thank you, Patricia de Vriend, who is a professor, doctor, occupational therapist, and gerontologist, among many other things. She is also an early adopter and a great supporter of primary care, such a great supporter that she has been able to start up an investigation research line at the University of Applied Science in Ghent. You would wonder, why perform a needs assessment in primary care? Don't we know it already? Don't we know what the needs are? There are a lot of articles out there who have described it very thoroughly, but still we at the University of Applied Science, which is a large word to repeat every time, next time I will say Artevelde, we found that it was necessary to press the pause button, because until 2021 we have been researching many things in primary care, but we realized that after a research period, the valorization of our research results was proven to be difficult. It was difficult to collect data, qualitative data. It was difficult to make sure that if we made or developed products to get them out there, so broader than to the one that has asked the research question. And we also had the strong belief that there was a necessity to work more together as research and education and practice and policymakers. And that's one of my main messages today, that from now on we need to do that more. Here you have an overview of our history. I will not elaborate too much on it, but as I said before, we have a history in practice research and primary care with good results, but valorization, implementation have proven to be difficult. We wanted to change that, and so we thought we will do a thorough needs assessment, a 360-degree scan. And the first thing we did was stakeholder mapping. And we thought, oh, that's an easy task, let's do that like in 1 hour, and then we'll know whom we have to interview. But it proved to be more difficult than that. Primary care is broad. Very broad. And we all had our personal and professional history to put on the table, but by doing so, we also learned from each other and realized that we all have our own perspective on primary care. I, for instance, didn't know much about occupational therapists in primary care, but my colleagues, I could teach them more about health promotion or mental health in primary care. And even though we learned from each other, we also learned that there were blind spots. And one of our greatest blind spots was that we have a history in care. But primary care has been reforming and from now on works much more together with welfare, but also with other policy like leisure time, education. So we had to learn a lot, and we learned a lot. We learned a whole new language, like geïntegreerd breed onthaal, sterk social work, strong social work. And that's one of our main findings when we interviewed our participants, is that they all said the same. We are with too many, maybe. It's difficult to know each other today. It's difficult to know who's out there, what they do, how we can find them, how we can collaborate. So knowledge about who's on the floor was really a necessity. And they reached out to us as a University of Applied Science to not only focus on promoting interprofessional collaboration by research, but also in education. They really stressed out that we are the ones who deliver the professionals of the future, and we really need to emphasize more on interprofessional communication from day one, if it is possible. On this slide, you can see how we did it. I will not bore you too much with methodology, but one thing I would like to give to you is that we really tried to hear everyone, from the GP who works daily with patients, to the social worker, to organizations at the meso level, to the policymakers. And we were surprised because it was midst of Corona. I didn't know which wave it was, 5th, 6th, I think we had multiple ones. But we had a lot of response. We had 44 participants who wanted to free their agenda for 1 hour or more to interview with us. So that's a great success. But we have to be fair. There was an overrepresentation of people in care. The welfare sector was less represented in our survey, in our needs assessment. And that's something we heard also in our interviews, that welfare in primary care is looked upon by care providers as the little sister or little brother. There's no feeling of equality yet, like being an equal partner. This was one of our findings. I only had like 10 minutes, so I really cannot give you all the insights we gained. I would like you to go to the website, which you can find at the end of, at the bottom of this slide, where you can read the full report. Now, that would be very easy for me to just say, go to our website and read the report. I do want to share some of the insights. It was not surprising for us that the runner-up, the gold medal of all the needs that at the first time came up with our respondents was all kinds of practical issues at the policy level. It was like, if you have to wave with a magic wand, what do you want to disappear tomorrow when you wake up? And they all said the same thing. We want to change the way primary care is financed today. They didn't all necessarily say, give us more. So that's very important to emphasize as well. There were a lot of ideas about how to shift the way money today goes to care. Fee-for-service payment was mentioned a lot, but another thing that was striking is that primary care actors also weren't always enthusiastic about project financing, because someone said, projects are normally things of short term, 1 year, 2 years, but often projects turn to be 4 years, 5 years, 6 years going on. So it was like, we engaged for a 1-year project and now we are still going on. Others emphasized that by project financing, what was lacking is that there was no clear view what after the project. It's like putting the carrot out of there, and then you may have tasted what it could be, and then you're like enthusiastic, you like the taste of it, but then the financing stops, and you go back to daily business. On this slide, you can see some of our other insights. What I would like to emphasize is that we heard quite a lot that today primary care is mostly associated with elderly people, but that we do not may forget the youngsters who also have specific issues like mental health issues. So that was surprising for us, that it really was a call for look at the whole lifespan, don't forget some groups. Another thing which was striking, and I am biased, but I was really happy to hear it, was that at the end of the interviews, like squeezing a melon and asking them to really wave one more time, then suddenly people started to say, especially the professionals, yeah, well, we really want to do more of prevention. We do not have the time today, we do not know how to do it, and we really want to come to that. So I'm really excited to hear it. Some messages, I hope there are some people who are policymakers today, but I already said it, project financing is not the Mecca. Really do also focus more on an implementation plan. Let local needs and experiments flourish more, give more room for experimentation. We, as an educational institute, but also the others, have a crucial role in playing and delivering the professionals of the future and focusing much more on interdisciplinary training, but also lifelong learning. We have lifelong learning courses, but they are professional specific, like for the nurse or for the occupational therapist. But in primary care, there is like a new wave of professionals who do not always have a background in care, who do not always have a bachelor degree, so they are not really appealed by those titles about those courses. So it's really important that we try to also get them on board. They also gave us the tip to change the way we offer courses, which are mostly remote, in-house. They wanted us to go out there, to go to the organizations and to implement courses there, but also to organize much more courses which are multidisciplinary. Today it's mostly unidisciplinary, and they really want to open that up and ask us to facilitate that. As researchers, we got the message, be tailored, speed up, really speed up. There is a real call for not elaborate investigations who take years and years and years, but we have a necessity nowadays, so help us today rather than yesterday. And they also wanted us to help them with signaling needs, but also solutions to policymakers. And we did that already and are going to do that in the future. I gave you some insights in the needs in Flanders. And now, as a University of Applied Science, we also had like asked ourselves, how are we going to do this? How are we going to help primary care? And one of the things that we are looking into it is to create an academic workplace, a collaborative center between and education and research and practice and policymakers, where we want to build a bridge between practice and knowledge, where we want to collaborate in a long-term way, in a structural way, and really help each other to prove and improve. So to collect scientific data, but also to improve society and have societal impact. We have put our first steps. They were careful steps. What we've learned already is that you need to have time to do that. You need to really get to know each other. So don't try to go there to practice, for instance, and say, here we are with our research agenda. You want to do that and build that up from scratch. You want to co-create it. You want to co-create your goals. You want to co-create your research questions. You want to co-create your research design, and you want to do the research co-creatively. So the keyword is co-create. Co-create and go for applied research. I hope that today there are here some people who are enthusiastic now about starting up a collaborative workplace, and I would like to invite you to get out there, to have your feet together with me in the mud. There's one pair there, but there needs to be a lot of more of them. It will be a long, messy and iterative process, but it will be a good one, a nice one, a challenging one. I would like to say, enjoy it.
Thank you very much, Sylvie. Perfect timing. And right now, Mr. Shiva Gab-deedam will join us online with his presentation concerning landscape analysis of primary healthcare integration. Good morning. Do you hear us?
Yes, I can hear you. Good morning. Good morning. Great to be here and connect with everyone, although virtually. I've been following through the sessions and I can see everyone enjoying the conference. I can see everyone at the Queen Elizabeth Hall. Can you all hear me and see me? Can you all hear me and see me?
Yes, it's okay.
Yes, Shiva, go ahead. Thank you.
All right, thank you very much. So great to be here. My name is Shiva Gab-deedam. I'm an associate here at Sydani Group, and I'd led this landscape assessment of health integration. It was a multi-country study, and we sought to understand the extent, the benefits, the barriers, and what recommendations or key considerations should be made to be able to integrate care successfully in resource-poor settings. So just going to start quickly on the slides. So one of the pertinent challenges of healthcare in low and middle income settings is fragmentation or verticalization of service delivery at the front lines. And really, countries struggle with balancing the need for resources and their own health priorities. There's a lot of funding coming from multiple partners, development partners in the space, and the countries struggle to balance that with their own health priorities. And this really has caused fragmentation and has caused verticalization of programs. So programs are running in parallel. And it's really pertinent, especially because resources are low, to really integrate care and share resources and use that to improve primary health care in these countries. However, health managers face the challenge of paucity of data to plan for primary healthcare integration, and hence we conceptualize this landscape analysis to improve and build on the body of knowledge for integrated care in low and middle income countries, sort of to bridge the gap in evidence between low-income settings and high-income settings. And I'll be discussing the findings from this study that was conducted from 2021 to 2022. The objectives of the study were to understand the extent of healthcare integration in low and middle-income countries, to explore the benefits and risks, and enabling factors to integration, and to even identify any possible solutions or approaches that will help chart the course for health integration in low and middle income countries. And this study was conducted in 3 countries, Nigeria, Nepal, and Madagascar. And it was 2-pronged. So first, there's the systematic review component of the study, and then the case study in these 3 countries that adopted a qualitative approach, where we conducted key informant interviews and in-depth interviews with health administrators at the national level, at the zonal level, health workers that are involved in planning primary health care at their different facilities. And we also explored the caregiver perspective to understand how all of this affects integrated care. So for the thematic review, we really focused on 2 sides. We looked at the peer-reviewed literature and we looked at gray literature. And for all of that, we developed search terms and combined these search terms using Boolean operations. And with the search terms, we put them into open source databases, and we generated search outputs from them. I would discuss each one in details as I then proceed to the findings. So first, for the systematic review, we got our search outputs as references. We got as many as 3,690 references, and we used the Covidence software to make our review very systematic, and removed duplicates and had that reviewed at multiple levels, at abstract level, at full text level, and finally, we conducted data abstraction to collect the data from the selected articles. And really here, we have the Prisma showing our selection process for the systematic review, and we came up with 59 articles, 48 of which were peer-reviewed, and 11 were from gray literature from different organizations that have been writing about integrated care and implementing integrated care interventions in low middle income country settings. And our study sites, like I mentioned, Madagascar, Nepal, and Nigeria. And for us to be able to select these countries, we first got the long list of countries that are classified as low middle income countries from the World Bank database, and we tried to look at, so I would like call out at this point that this work was funded by Momentum Country and Global Leadership, and with support from JPIGO. So we looked at countries that had JPIGO support amongst the lower middle income countries, and we also had to obtain buy-in from the Ministry of Health, so that informed the selection of the countries. This really kickstarted just after COVID, so we really struggled with getting buy-in across multiple countries, but we're finally able to get buy-in in these 3 countries. And for our sample population, we explored insights at the national level, at the Ministry of Health, where we conducted some interviews. And for Nigeria specifically, we also conducted some interviews at the level of the National Primary Healthcare Development Agency's NERIC team, which is the National Emergency Routine Immunization Coordination Center here in Nigeria. And we got to get a lot of insights on coordination of care and policies at the national level. And we did this also in Madagascar and Nepal as well. And coming down to the lower levels, we're also able to get some insights from people at the subnational level. I'd really say that the study was a lot. We were able to do a lot more interviews in Nigeria than we were able to do in other countries, because we are here in Nigeria, and it was easy to conduct the study very in a more in-depth way, as opposed to in Nepal and in Madagascar. To do that, we had to engage research assistants across all the countries and teach them how to use the tool and to understand the tool. We had to translate the tool to Nepali, French, and Malagasy, and deploy them to conduct the interviews, both virtually and in person. So some interviews were conducted virtually and others were conducted in person. Going down to the facility level, we're also able to speak with health workers, specifically the officers in charge, the officer responsible for planning immunization services, routine immunization services, RMC services at the facility, and get their insights on health integration. And likewise, we spoke to clients at the different facilities where we interviewed the officers in charge. And we put all of that, and I'll go straight to the findings. So I'll be discussing the findings across our research questions. first we want to understand the extent, and this extent is in terms of the types of integration and the availability of policies across the different countries. We also look at the benefits and risks, barriers and solutions and enablers. So first, looking at the extent of health integration. For our own study, we adapted the WHO definition of integration, and we defined it as the management and delivery of health services so that people receive a continuum of health services coordinated across different sites of care and according to their needs throughout the life course. And we found that the most common forms of health integration in these countries through our interviews and through our systematic review were integration around immunization services. That was really the most common form of health integration. And for immunization, it existed in two forms. First, where the other health programs are tied around immunization. So where there's integration of other health programs into immunization, and then there is integration of immunization into other health programs. And on the side of integration of immunization into other health programs, we can see where in situations where caregivers that are receiving family planning services at the facility also present their infants for immunization. We can also see that in cases during sessions of PMTCT, that's prevention of mother to child treatment of HIV, and you see immunization services being conducted in these settings, and immunization of infants during COVID-19 vaccination, wrap-up activities in Nigeria. And really on this side, it's more around using integration as a strategy to improve immunization coverage in places where, or in priority settings where the caregivers are more open to receive other services. So immunization is layered on these other health programs, and it leads to reducing missed opportunities for immunization in these settings and address the challenges of zero dose. For integration of other programs into immunization is the backbone, and the other services are an add-on to immunization. So using immunization as a route to improve demand and improve uptake of other services such as nutrition services. And this is seen very extensively here in Nigeria with the implementation of OIRIS, where there's the delivery of nutrition supplements and other commodities to infants during immunization that is conducted through outreach sessions. And then on the other side, we have integration of other vertical health programs. So here we have a lot of findings around the integration of HIV and TB services, where you have in a health facility, you have the HIV and TB services being provided at the same facility. Sometimes it's provided in another section or a particular section of the facility, which is the TB center, and TB and HIV are being managed together. And there are also multiple examples across non-communicable diseases and other program areas in health. So I tried to summarize the findings across the policy review, across benefits, barriers, risks, and the solutions preferred to because this is very well detailed in multiple reports, so I couldn't go into all the details, but the highlights are for the policy review, from our systematic review and from conversations with key informants across multiple countries, we were able to obtain policies that were published in English, and we reviewed some of these policies. We used the CDC policy analysis framework to review the policies, and we really found that in low middle income countries in general, health integration is actually on the agenda. It's actually on the policy agenda of these countries. You can see that in their health planning and all their health strategic planning documents and policies. You can always see integrated care being called out specifically as a priority for the country, especially for RNA-CH services and immunization services across these multiple countries. And reviewing some of these policies, we really found that these policies are shown to have some form of public health impact across the different countries. And although we couldn't really assess the economic and budgetary impacts of these integrated care interventions, because the policies didn't always come with the budgets alongside them. So we always had to just look at it on a general view. And even the conversation around cost effectiveness of integrated care, we try to use the budgets of the policies to even understand and see how we can assess cost effectiveness. We struggled with that limitation, so we were not really able to explore that option. But from the literature review side, there were multiple schools of thought in terms of how integrated care affected or whether it was cost effective or not. From the provider side from the caregiver side across multiple countries, it was clear to see that integrated care they were actually very welcome to integrated care because they felt that on the side of transportation, it reduced the number of visits that they needed to make to the different health facilities. So they were able to save up some money, they were able to make some cost savings in terms of transportation if they had to go as many times as possible to the different facilities. Other benefits that we teased that were increased uptake of services on the immunization side, resource efficiency, increased capacity of health workers, and prevention and early detection of diseases. For increased capacity of health workers, we really found that health integration, actually in Nigeria specifically, there's the tax shifting and tax sharing policy that is being implemented here in Nigeria. Although we are challenged with the issue of the number, which we don't have sufficient healthcare workers at the different facilities. However, the tax shifting and tax sharing policy has been able to help us maximize the available healthcare workers at the facilities, and where you have healthcare workers of lower cadre being taught and having gone through some off-site trainings on the other skills that they would have had if they were working at a higher level. And this has helped to optimize and increase the capacity of health workers at the lower levels. And integration has been proposed as a strategy to improve coverage of immunization services and reducing missed opportunities for vaccination. And it also shown to have some cost benefits, especially for immunization. For the barriers and risks, 6 key barriers really came out. And first was the inadequate number and skill of health workers, poor financing, inadequate supply of medicines and resources, lack of policies and guidelines, verticalized M&E systems, and poor community engagement. So from our study, we found that the struggle here in low-income countries to integrate care is really even more on the side of having the available in terms of financing, in terms of getting the adequate number of healthcare workers that are skilled and having the commodities available. So it's more there are more system side challenges for middle income than in higher middle income countries or higher income countries, as it were. And the risks some of the risks identified from us were increased health provider workload. So even if we're trying to maximize the limited healthcare workers at the facility, they really struggled with workload because the healthcare workers are already stressed and already struggle because the patient to healthcare worker ratios are very high. So they really struggled and trying to even integrate care further increase their workload. And there's also the challenge or the risk of inadvertent disclosure or stigma, especially in facilities that use the one-stop shop approach to integrating care, where people or other caregivers or other clients at the facility where they're going into a private room to receive counseling for HIV or maybe, for example, doing in a TB center, for example, that can lead to disclosure and stigma from other clients at the facility and in the community. And then there's also the challenge of poor quality of care, which resonates in the lower middle income country settings because of the system-wide issues that are being faced. Although this was not corroborated by client interviews, but we found this as one of the risks and challenges to integrating care in lower middle income countries. And many solutions were preferred, recruiting healthcare workers, building their capacity, and we've got a lot of information around even integrating or putting in integrated care into the modules of the health workers when they are in their training institutions to already create that awareness of integrated care so that it can bridge the gap of knowledge and practice. Because what happens is most times they're not taught how to integrate care at the institutions, but when they're at the facilities, they're expected to do some form of integration. So another solution was, of course, providing adequate and sustainable financing, providing the required drugs and commodities, developing easy-to-use decision aid tools for healthcare workers to address capacity gaps, define goals and outcomes for integration in each country, and develop an integrated M&E system, and being intentional about community engagement. Community engagement really came out as an enabler for improving the acceptance of integrated care in the community. Finally, to the conclusion, so what should we really consider in terms of integrated care in low and middle income countries? 5 key things are important: context, feasibility, compatibility, acceptability, and accountability. In designing integrated care interventions, context, the local context must really be considered, because what approaches that might work somewhere may not work in other settings because of how nuanced our primary health care is in these settings, because a lot of adaptations have to be made to suit or to fit the design that we're trying to create. Feasibility, different primary healthcare programs need to even be checked for feasibility, because we found out that compatible programs like immunization, family planning within the RMNCH space, really a lot of extensive work has been done in terms of integrated care in these settings. And then next is compatibility. Are the interventions compatible with each other? Are they feasible in the settings? Can we integrate the services? And how is the level of acceptance at the community level, which I spoke to about community engagement and how community engagement can be an enabler for integrated care. Because in resource-poor settings where we don't have financial protection in terms of health insurance, all of these have not yet been fully structured and fully formed. You have to even reach out to the clients so that we can manage their expectations when they come to the facility. They know that they're going to be paying for multiple services, and that will even help acceptance in that sense. And then in situations where services that are provided are going to be free, it's also important to communicate to the community that they will be free, and this can improve acceptance for integrated care. Finally is accountability. In trying to move the needle, there is the need for improved coordination and accountability. So for the funds that we already have, how can we set up systems that are tied to the monitoring and evaluation systems that can help us to even be able to make informed decisions and be able to plan effectively and manage the available resources for integrated care. And finally, our study limitations. We could only review literature that was available online and published in English. For our key informant interviews, we're also able to get some hard copies of some of the policy documents that we reviewed, but we were not able to get the budgets for the different policies to be able to even assess the cost effectiveness of the different interventions or the different policies for integrated care. And there's also paucity of information around the level of implementation of some of the integrated care strategies that are being implemented at subnational level in these countries. And the last limitation was slow response from the ministries of health of some of the selected countries to grant approval for the study, because they were really hit by, they were hard hit by COVID-19. So we had to wait a little bit, we had to change countries, and we finally got the approval and we were able to conduct this study. Thank you all very much.
Thank you very much. Please stay with us. There are questions from audience, which we plan to ask at the end. Dr. Caroline Nicholson, please, the floor is yours.
Hello, everybody, and welcome, and thank you for coming to the session. It's great to see everybody. I'm going to present on governance for health system collaboration through the experience of setting up the Southwest Primary Healthcare Alliance in Queensland, although from what I've heard over the last number of days and even the previous two presentations today, I think we'll always find that there's a lot of overlap in our problems. Our context might be different and our setting might be different, but really I feel like I'm sort of repeating what other people have said, which is a good thing, and hopefully we can kind of work together to get where we need to be. First of all, I want to acknowledge the fellow authors in this paper, which is Professor Claire Jackson, Dr. Anthony Brown, Sandra Gillies from Australia, and Professor Robin Gold from New Zealand. I'd also like to acknowledge in the southwest area where this research took place, the 18 traditional and cultural custodians of the lands in which the study was done or is being done. We recognise that Aboriginal people and Torres Strait Islander people within their respective communities each have their own unique languages, beliefs, cultural practices, traditions, and diversity. So, I'm going to very quickly go through sort of just what our research approach is, what the alliance is and how we got to having an alliance, and how we're planning or how we've started to measure what it is about an alliance that can create success. So our approach is, and I think Sylvie mentioned this, the co-creation approach. Ours is the co-creation in health services research. It's been published, which you can look at. But really, the key here is that the research end users are critical and willing partners in closing the evidence, practice, and policy loop. It's great to know what the evidence is, but until the research end users actually know that there is a need and that they can use the evidence to help bridge that gap, then applying it, and as Sylvie said about the implementation, it makes it very difficult. So that's the approach that we take. The problem that we had, I'm not sure you can read all of this, but basically the burning platform in the southwest was identified in February 2021 locally by the health providers in the area, and really it was an unsustainable workforce. They had increasing rates of potentially preventable GP-type presentations to ED. They also had a general practice workforce that was basically declining at a rapid rate. So the organisations in the southwest area are those with the logos across the top, and I think John Eastwood described the meso-level organisations yesterday, but whether you call them primary health networks, primary healthcare organisations, primary health, whatever, alliances, they're those organisations that are at that sort of meso level that come together, and I'll go through them in a second. So the CEOs of the Health and Hospital Service and the Primary Health Network, which have a sort of geographical overlap, came together and they sort of said, we've got to do something about this. They agreed to bring us in. They sort of talked about this for about 12 months, about what the problem was and what they were going to do. So then they sort of said, well, how does the research help us create the alliance and actually demonstrate that the alliance is the way that we should be going? So the Southwest by numbers, this is a pretty quick shot of what it is. So the green area, this is the state of Queensland in the bottom right-hand corner, all of the grey and the colours. The southwest is the bit in the red circle and the green bit. Its catchment area is 319,000 square kilometres. And by comparison, Belgium is 30,005 square kilometres. So Belgium's the little blue bit. The green bit is the southwest. So it goes into it about 10 times. And the population, however, is just under 12 million for Belgium, and for this area it's 26,000. So it's a big open space. Trying to get care to people is quite difficult. It is quite remote in many areas. The health services, there are 3 public hospitals, there are 8 multipurpose centres, the 4 Aboriginally controlled community clinics, 12 general practices, 3 of them are private, the others are run by the Hospital and Health Service, 2 residential aged care facilities. We have our RFDS, the Royal Flying Doctor Service, that covers the area, well, covers the state, but that area as well. And also we have fly-in, fly-out and virtual access to specialist and allied health care because it isn't actually on the ground and available. So what did we do? The first thing we did was we did a rapid review. We actually looked at what other evidence, state and national policies, really to see, well, are we barking up the wrong tree? Is this something that the policy is going to support? All of these policies, and I'm sure every country has lots of policies. We all seem to like policies. But basically, they did articulate the need for improved system innovation, productivity and efficiency. And so the partners to this alliance sort of said, well, you know, we're going in the right direction, but how are we going to do this? It was emphatic when you looked at all of the different policy documents that, you know, these were the things, and we've heard a lot about this over the last couple of days, you know, whether it's funding reform, the population approach, change leadership, integrated pathways across the continuum, innovation, and how we use data in a meaningful way for a system, not just for an organisation. These were pretty consistent, dominant themes that came through all of that. So we took that, and my previous work is developing an integrated governance framework for integrated care. There's a thesis link on the bottom if you want to really sort of knock yourself out. But basically it came up with, in the second column, these 10 elements were the things that are needed for these meso-level organisations, if they're going to work together, to address pretty much all of these in some format. And again, we recognised that what the policy documents were saying was covered by the evidence. And so we used this as a thematic analysis with the stakeholders and said, well, this is what what you need to do in these areas, and how are you going to use it? So they came up with, I know you probably can't read this, but it's the 5-year plan. The arrows on the left are how they put together those 10 elements. The elements aren't really prescriptive. It's not to say you have to do this, this, and this. It's for each organisation or each alliance to say, how do we do system innovation? How do we do joint planning, joint education? The idea is you cover off on them, but how you cover off on them really depends on local need, and everywhere is different. Even from northwest to southwest in the same sort of geographical areas, they still have different problems, and how they use it is different. So they came up with their own 5-year plan. The key priorities were in the right-hand column, and the next column over was the proposed solutions. And it was at this point they thought, now we need to know how we're going to do this. This is all very well, but so what? We've been here before and we don't know what we're going to do. So the idea of an alliance was formed. The Tier 1, which is in the red circle on the right, these are the organisations, and these are the people who are, the members have the capacity to lead, they have the capacity to influence and to partner. They can make the decisions, whether it's the chief executives, it's the lead health professionals, it's a representative from private general practice. They're very skills-based, and it has to be based on, and each of the organisations in the alliance had someone on that group. The Tier 2 then were the people within those organisations tasked with the doing, and then at the bottom there were various work groups, and they decided the 3 that they wanted to work on was workforce, because that was the problem, digital, because we had problems with lack of interoperability, and also mental health, because there's a significant issue in the area. So the first thing we did was we developed a charter, which is on the left, and that outlines the rules of engagements and commitments by members, which is pretty much to act honestly, to work collaboratively, to be person-centred and have a system approach. They all signed off on that, which is the sort of picture of the areas where they can sign, and they've actually agreed to commit to a period of time to do this work. This sort of work is also focused on building the collaboration around that whole system approach. So we came up with a governance framework, which is the document in the middle, and that sets out the roles and responsibilities of the alliance, not of the organisations, but of the alliance. And again, they commit to that, and that's where this organisational structure came from. It's difficult and it's hard and it takes an awful lot of time because everyone's got their day jobs, and it's really, don't underestimate what it does take. But for members to focus primarily on the community rather than their organisation or individual circumstance is actually quite a significant change, especially when they are faced with some significant issues in running everyday life. So what we did was, just as an example, in the grey box at the bottom was the workforce working group. And I'm just going to show this because this was the workforce implementation strategy. Now, as far as you go when you're doing a specific project, it's actually quite relatively, I should say, we need to look at how we share data, how we overcome those digital problems, how we innovated, and what new models of care we could try. But each one of those has specific KPIs and specific outcomes, and we can measure them. The real problem and where we came to with this was, but how do we measure the alliance? How do we know that at that Tier 1 level, it's going to work? We can measure the outcomes as far as on the ground, but how do we know that the alliance going to work, and that's pretty much where we're at. So it's really about that normative dimension of integration. It's about the values and the trust and all those things that you kind of think everyone mentions, yes, we need those, but so what? You know, how do you know if you've got them or not? So what we do know is that there are some key elements of partnership or alliance working and governance at that meso level which stakeholders can use, and they develop the plan from that. We know that some alliances and partnerships are successful, and John Eastwood mentioned those yesterday. There's Canterbury, there's Alliance North, which Robin Gold, who's an author in this paper, was very fundamental in developing. But not all are. And even though they have a policy in New Zealand from 2013, I think, to have alliances across the country, they don't. So policy alone won't work. It's actually about how do you get those people to buy in and make it happen. We know that trust and relationship building are key parts of the experimentalist governance model, which forms the basis of this collaborative governance approach. However, trust and relationships and leadership alone will not sustain change in complex systems where there are different organisations with different cultures, capabilities and resources. The lack of robust governance arrangements does pose significant risk to sustainability. What are the mechanisms which hold the alliance accountable for collective governance? These are rarely, if ever, discussed in the literature. So what we don't know is how do we measure it? And can we use an implementation science approach to measure what the secret source of that alliance is? And this is where we use an implementation science approach for other things, and I'm preaching probably to the converted. But basically, it's the aim of that is twofold: to identify the barriers and enablers across the multiple contexts of individual organisational system. It's also to develop and apply the implementation strategies. And like Sylvie just said, you know, we've just got to get on and implement, but we have to look at how do we actually do that in something like in this area. Now, most will know about effectiveness and implementation hybrid designs. I'm not here to give a lecture on that, but this helps us to help to explain the distinction between effectiveness and implementation. So in essence, effectiveness studies investigate whether an intervention or practice works. An implementation study investigates how to best influence change in practice. So that's the kind of approach that we take. There are many different implementation science models, and we've heard about a lot of those over the last few days. Some of these have their origins in evaluation, but are now commonly included under the implementation science umbrella, and also the ERIC, should say expert recommendations for implementation of change. There's a typo there. So things like the quadruple aim and the consolidated framework for implementation research, we call it the CIFA, these are commonly used, and I've heard these been mentioned previously in the last few days. Each of these do different things, and it's difficult to know when to use which and how to integrate them into a coherent assessment of implementation. So we use, and we have used for other initiatives, the Implementation Research Logic Model, because it's shorter, and it uses a pipeline logic model to format and integrate implementation science models, theories and frameworks so that they can be more easily used to look at how to assess implementation. It's not a framework in itself. It's actually a way of organising and applying existing models and theories directly to an innovation. So we applied it to the alliance model that we're doing. So the intervention is the logos there in the middle. That's the alliance. So we're using it here, if you look at it, to plan, to execute, evaluate, and then report. So it's combining the various different models or theories. So the CIFA is on the left, and these outcomes here have come from the stakeholders, not from me. We asked them to actually do this. And they have to look at it from the alliance perspective about, for the determinants of the implementation, what are the barriers and enablers across the multiple contexts? And you can see the context down the side. There's the intervention characteristics, the inner setting, outer setting, characteristics of individuals and process. And it's actually really hard to do. I've done it a number of times. And when you're actually looking at it from that whole perspective, it really it's quite difficult. And I've had a number of conversations with people who are trying to fill this out going, what do you want me to do? Like, can I do it from this perspective? No, you've got to do it from here. And it really makes you think. You should try doing it. It's not easy. So that was the CIFA. The ERIC the strategies area is looking at what those strategies are that can help overcome the barriers and enablers and increase the uptake of the innovation. So it's put into an Excel format, the CIFA, and there's an algorithm behind it, and it generates the ERIC. And they give you a whole list of different strategies, and you choose collectively with the Alliance people, you choose the ones that you feel are the most relevant, normally within the top 10, there's a lot of them, that you think that are the most doable and relevant and appropriate for the setting in which you're in. Then there's the mechanisms, and this is the change context or the behaviours within those contexts that you need to put into place. And then there's the outcomes. We've used the Proctor, you could use the REAIM, but it looks at it within the outcomes areas of implementation, so it could be adoption, fidelity, sustainability within the service, and so that can be safety, effectiveness, cost. And then there's the clinical. Now you choose again the ones that are relevant to your intervention. There's many more than that are on there, but I just chose, well, the ones chosen were the ones that were related to the intervention. So this is where we're at, and this is where we've started. As I said, we know that this works for other interventions, and what we're trying to do now is test it against the Alliance. So I should have the actual results in 12 months' time. But the Alliance themselves have it's been a fair journey, I have to say, to do this so far. But we do hope to look at whether we can measure what makes an Alliance work. So the learnings, very quickly, are the components of the link with each other. And we've shown that time again. The strategies are required to address implementation at different levels of the determinants. You need to do individual, organisational, policy levels. The mechanisms are probably the most challenging bit, to both conceptualise and to measure. And using the model, it's iterative over time, whether you're doing it at the pilot stage or the implementation or the scale-up stage. You're looking at it from one perspective, but every time you do it, it sort of takes you back, and are we staying true to what we're actually trying to measure? It's not just set and forget, it is actually an iterative process. And as I said, we'll have the Alliance actual outcomes, I hope, in the next 12 months. And finally, in summary, and I think Sylvie also mentioned this, but the co-creation methodology for us with research end users has been phenomenal. They've been extremely committed and trying to look at how the evidence can support what they're trying to do, I think has been very useful to them from their feedback. The Alliance came about because of a common problem and the need to work together. To do this just because it's mandated, in my opinion, and the work I've done is difficult, but if you've got a burning platform, it helps. A locally agreed 5-year plan for the Alliance was developed by using the current evidence and letting them apply it locally, so the evidence is supporting their implementation. And as I said, the assessment and the outcome should be available in 12 months' time. Thank you.
Thank you very much. Thank you. I invite Peter Depoot.
Good morning, everybody. Thank you to the organization for allowing me to speak here. I'm standing here before you very humble because I saw all this nice work from PhD students, researchers, professors. I think I'm a simple primary healthcare worker in the southeast of Flanders here in Belgium. Secondly, it's my first time I do a presentation in English, which is not really my language. If it was in French, my second language, it would be better. No. So in 15 minutes, I would take you a little bit and tell you a little bit of the story of the primary care facility, the Piramide in Menen. Menen, as you can see, or not, is in on the map in the east-south of Belgium. It's a border city which features of Menen 30,000 inhabitants located in the southwest of Belgium, poverty, bad condition of housing, and very aging population, and a great immigrant community in our city. In 2015, 2016, with 4 GPs, we did a SWOT analysis of the primary care system or in Menen. What we noticed was a shortage of GPs. In the last 20 years, they started just 2 new GPs in Menen. So it was very difficult for them to cover all the problems of the population. They also mentioned little support in their consultation room. They had to do all by themselves, administration, lack of nursing, and so on. Also, they claimed the need for interdisciplinary dialogue. They were confronted with several nurses, several physiotherapists, and so on. So they thought they couldn't easily work on the interdisciplinarity. Also, a lack of care coordination. Also, the self-reliance of patients. And our system, fee for services, we keep patients dependent on care, we think. Also, a lack of prevention and health promotion. Vaccination strategy. We didn't know how many people of our population were vaccinated for flu, for example. Also, the place of the patient, we didn't know. Quality, how do we measure some outcomes of patients? How can we see if the things we do it well? We didn't know. Also, yes, we think we have a great expectation for new healthcare professionals, so we must train them. We didn't do that at the time. Innovation in care, we did it like we did it the last 20 years. And also pathways for several chronic diseases, we didn't have it. So we thought we have a great vision and a great mission. We go for interdisciplinary work under one roof. We will focus on prevention and health promotion, a very community-oriented care we offer. We would be a training center for various disciplines, innovation, introducing innovation in our practice will be great, and also measure the things we do, the quality. So that was a very nice vision, a very nice mission. Therefore, we had to leave the fee-for-service model and we get into the capitation financial model. Now you think that's a nice vision, that's a nice mission, everybody's happy. No. We got a huge counterwinds. Here you see a pamphlet of the liberal political party who claimed that our center would attract even more people in deprivation. So it was very bad to have such a center in Menen. You see the Piramide is bad for Menen, or even our mayor who suggested it in a letter to the province that it was a good organization. She was on, and yeah. And this, okay. Also, the healthcare professionals or colleagues, local healthcare providers, they saw this as an unfair competition, ideologically not fitting with their vision, based on fee-for-service. Capitation is something for communists, socialists, I don't know. Even our Minister of Health, which name I don't remember, in a previous life she was also a GP, she wouldn't sign the agreement on capitation, but lucky for us, after 8 of 10 months, she capitulated and signed. But nevertheless, we continued. We think what it was good, we continue. So we started in January And we couldn't start in the capitation because the minister wouldn't sign, so we started in July. 6 months, no income, but who cares? Meanwhile, the center experienced a great growth. We started with 4,000 patients. Now we have 6,000 patients who, who choose for us, who choose for the Pyramide and for care. We have several disciplines in our center, GPs, care coordinator, reception and administration, nurses and care assistants, physiotherapists, occupational therapists, speech therapists, social worker, dietitian, diabetes educators, nursing home care experts, psychologist and staff member quality. So it's become a great organization. We have 50 persons in our organization. Of course, we now in our new vision, we go on and we use the quintuple aim model to guide our operations, with thanks to Vivel for the nice presentation. Now we're going to discuss 3 parts of our working. And innovation, prevention, and care pathways. And in innovation, I will show you 2 things we do. We have a self-measurement kiosk and a home platform. With the self-measurement kiosk, patients can measure their blood pressure, pulse, saturation, temperature, weight prior to consultation with the GP or whenever they want. We now see that several patients visit us once a week to go to the kiosk and measure their parameters. We can also add additional questions. The first question we have added to the kiosk is, do you smoke? And if you smoke, do you wish to stop smoking? That's very good for the results we use for our preventive programs. 4 times a year, we have smoking sessions or cessation sessions supervised by a tobacologist. So we, all the patients who want to stop to smoke, we invited them to the sessions. In addition to the kiosk, there is also a home platform where we can follow up patients online. The first application we used in the home platform, we are searching a little bit, is patients suspected with high blood pressure. We gave them a blood pressure meter from the center, which then automatically connects with their smartphones to the platform. This allows us to monitor blood pressure for 40 days and adjust our policy accordingly. A second pillar in our operation is prevention and health promotion. To this end, we have launched the #Gezond program in our center, #Healthy program, with various actions for all this. For example, you see here the sessions by our psychologists for young people around self-image. Our dietitian teaches us how to correctly read food labels. There are also our monthly exercise afternoons for older people, where we have 2 objectives: getting older people exercising, of course, and after this, there's a social event with coffee and cake. So we combine exercising and a social moment, which is very good confronting isolation for elderly. Elderly who cannot get to the center on their own, because there are much elderly people who aren't so, who can't go to the center. For example, the people who were registered by our home nurses, we pick them up by our cars, and the volunteers bring the patients, 2 of the persons, to the center. Meanwhile, we are working with the residential care centers so that we can organize these afternoons every week. Here you see some images of beweegnamiddag. And all the people seems to be happy, and we also. A third pillar is our pathways. We have already launched, realized a number of them. The wound care, collaboration between one of our GPs and the expert nurse wound care. They see the patients with wounds on a weekly basis, so they can give targeted medical and nursing advice. Diabetes. We see from the start that our patients are better regulated with the efforts of our diabetes educators and dietitians. Obesitas, we have our own program to reduce obesitas. Historically, we take care of substitution with methadone, so we also have an interdisciplinary pathway for these patients, and now we started with the program of neck and back pain. As you see, there is a large group. In the statistics, we see that 40% of the patients who are going to the rehabilitation center or revalidation center are patients with neck and back pain. This is a large group, and obviously we need to look at how we can help these patients in a good way. For every program we start, there is one process counselor. The process counselor is in close contact with the patients following programs. He or she captures points of improvements, points of attention from the patient's point of view. So that's very important. We have little protocols. Here you see a little protocol to go with lumbar. So we started the back school. Back school is known here in Belgium also by the hospitals who organize it, but we think it can be organized at the level of the primary care. You see the difference between the hospital and us. In the hospital you have a specialist. In the primary care facility you have the GP. But we have physiotherapists, we have occupational therapists, and we have psychologists. So the program is the same. Second, if you choose for the hospital, you have to go to a hospital. And not in every city there is a hospital, thus you have to make, you can go to there. But here, in the Pyramide, of course, it is much more comfortable for patients to come to our center. They arrive here in a familiar environment. They know us, with people they know, the reception. They don't have to move to another center. So we think it's more comfortable for patients to come to us. The advantages is also that in primary care patients are continuously followed up by us. In hospitals, they come time for the back school and they disappear. When we look at the costs, we can see here the quintuple aim. For the community in hospital, yes, it's a very, the age 60 is a great number, and the patient has to pay about €300 for the treatment. By us, the cost is in capitation, so everything is paid for them, and also it's free for patients, they don't have to pay. And of course, we have the same equipment in hospital, in hospital or in our practice. Here you can see the training in the Pyramide, the David Beck training. So it's similar in the hospitals. With these 3 examples, I try to represent part of the vision of our center in 15 minutes, and it was not easy. But what you don't have to remember, I think everyone wants change, but when we say we're going to change, there's a quiet of silence. If you want to see more about us, just visit our website, and thank you for your attention.
Thank you very much, Jocelyn.
Good morning. Pauline Pariser will be co-presenting with me, and between the two of us, we have 67 years of experience delivering family medicine and primary care, and about 50 years of experience in the leadership of primary care.
We started when we were 16.
Yeah, we were just kids. In Canada, we are facing a significant crisis in family medicine. There's a growing shortage of family physicians, and right now in Ontario, 2.2 million Ontarians do not have a family physician. Many physicians are retiring, and new grads, as I'm a teacher of family medicine, are not choosing comprehensive family medicine. They say the administrative workload is too high. With our electronic medical records, they have difficulty finding the right referrals and making them. The complexity of patient care is growing, and there's a very poor team-based care in Ontario. So although we know that team-based care makes a difference, and this was actually proven during the COVID pandemic, most family physicians in Ontario and in Canada are not supported by a primary care team. So when we look at enablers of high-functioning primary care, you can see on the slide that there are a number of areas, including access, navigation, supporting seamless care delivery, integrated team-based care, providing comprehensive care coordination, and advancing interconnectivity. However, we've added in red our joint experience and the work that we have done in improving primary care integration and navigation. We need to make sure that family physicians are able to access the care in a timely way. When I've got a busy clinic running with a waiting room full of patients and I've got a patient I've got to connect to services urgently, it is very, very stressful. So we need to reduce that stress. We need to improve the administrative burden. We need there to be one point of contact for family physicians to access the care for their patients. Of course, we need team-based care, and we really need to support our family physicians in providing that comprehensive care. So last year at ICIC 2022, we held a workshop, and at the workshop, we together created what a vision statement could look like for simple navigation supporting primary care. So that vision statement, relationship-based navigation is the underpinning of team-based primary care and essential to improving system navigation. I have to say that here at this conference, I've heard a lot about navigation in all kinds of different settings. The more navigators you add to a system, the more complex it gets. So we've got cancer navigation, we've got diabetes navigation, but from a primary care perspective, we need simple navigation. So I'm going to hand it over to Pauline, and she's going to talk about some methods that we have co-created and evaluated that are efficient models of helping family physicians navigate healthcare for their patients.
Thank you, Jocelyn. So these two models really exemplify relationship-based primary care integration with navigation as the core element. So the family physician is at the center, and really through the navigator is able to access a complete range of services, whether it's a direct connection with a radiologist, home and community care, various specialists, mental health services. And I loved hearing from Sylvie and Carolyn the word co-creation, because the navigator helps identify with the family physicians gaps in care to create more and more new clinical pathways. So SCOPE, which stands for Seamless Care optimizing the patient experience is a virtual team with a navigator at the center, and it provides a virtual care team primarily for those family physicians who are not already part of teams. We started with 30 family physicians with whom we co-designed the program, and now I'm pleased to say we're up to 2,300, 9 sites in Toronto, and a range of sites outside of Toronto in rural communities, Indigenous communities, looking at local population needs. It's become a very effective platform for primary care integration, and that is because it's driven, led by, and for those providers. So you'll be familiar with the people-centered medical home, which really forms the framework and aligns with both programs I'm going to speak about. So foundationally, there is connection to administration, to stable funding, and to connections with the various services across the continuum. And then the program itself, the operations led and stewarded by primary care provides better access, continuity, and a range of connections to community and hospital services. And then to scale and spread, of course, the umbrella has an ongoing measurement and identification of what are the needs of the team so that you can maintain and grow a robust team. So how SCOPE works is there is a single point of contact. Family physicians told us, we don't want a lot of passwords, we don't want a lot of referral forms, we want one single point of contact. And that's often through the phone or through a digital mechanism, and either through the nurse navigator or directly, they connect to a dedicated internist, a dedicated home and community care coordinator, a dedicated nurse navigator who gets to know them and their frontline staff. And because we were continuously co-designing with family physicians, they told us, you know, we send a lot of people to hospital because we can't get imaging. So they have a dedicated radiologist that they can speak to understand what to order and to expedite urgent imaging. The critical success factors to build a program depend on that single point of access, also on a community, a committed local primary care colleague who champions the program, who helps socializes it, who reminds family physicians about why it's essential service for them, that there is hospital executive support. This needs to be endorsed at the highest level. At Jocelyn's Hospital, her CEO went to family physician offices to help them sign up for SCOPE, because from his point of view, this was a win-win situation. So he really influences the specialists to say, when the nurse navigator needs your help, you better be responsive.
I'll just give one quick example. Our CEO heard from our family physicians that they couldn't access our fracture clinic. They had to send patients to emerge. The next day it was changed and they could all access our fracture clinic.
So where this hasn't existed, the program hasn't been as successful. Having a dedicated SCOPE navigator is the most important position, and partnerships across the continuum, and obviously a method of evaluation. So the next program, thank you, is called TIP, for Telemedicine Impact Plus. It's also a model of care that was launched similar to SCOPE about a decade ago that uses video conferencing and virtual multidisciplinary teams where the patient and the family physician attend the conference. So that enables comprehensive care planning. It was chosen by a research group from Western Ontario to become, Western University, to become the chronic care model for Ontario, to be evaluated as part of a national randomized controlled trial. And really the goal is to support primary care providers and their patients who really struggle with the healthcare system when they live with multimorbidity. So what makes these patients' care needs complex? Well, you'll probably recognize these patients as I describe them. They don't have one condition. They usually have at least 5. They struggle with polypharmacy. They concomitantly also have a struggle with mental health issues or drug substance use challenges, which means, and they don't often meet the social determinants of health. So they live in poverty, they're socially isolated. Often their various body parts go to different specialists. They're managed with serial visits. The number of providers, the number of visits, the number of complications make it excessively difficult for their primary care provider to manage. They often have poor mobility, so they don't get to the primary care provider or the specialist appointments. So that means that they're not well connected. And all of these things contribute to increasing adverse outcomes, including multiple visits to the emergency room and readmissions. So again, we use the patient-centered medical home, which aligns very well with this program to build the capacity of the program to incorporate interdisciplinary teams with the family physician at the center. So the referrals come from the family physician. Sometimes patients self-refer, and the critical person is that tip nurse. So she meets with the patient in their home. That's incredibly important for these people who can't get to appointments, and figures out with them what matters to you. On the basis of that, she chooses one of 12 teams and organizes a video conference, which is about an hour, provides all the background information. Those teams unpack the case, come up with a coordinated care plan that the nurse then takes back to the family physician and the patient, and stays involved with the patient for up to 6 months. So that very complicated case doesn't land back on the family physician's shoulders. Who's part of the team? Well, we have the home care coordinator, oftentimes a dietitian, a social worker, there may be specialty nurses. Invariably we have a pharmacist, and usually a specialist, whether it's a geriatrician or internist, and a psychiatrist.
I just want to say, as a user of TIP, we also tailor the teams based on the needs of the patient. So we will have our diabetes team attend if it's appropriate. So we really try to tailor that.
So this is a visual. That's Samir Sinha, who's a noted geriatrician in Canada, sitting beside the home and community care coordinator and social worker, the geriatric psychiatrist, the pharmacist, and then on the screen is the tip nurse with the patient and the family. Back to you, Jocelyn.
So in conclusion, we need a simple model of navigation in primary care, stratifying the intensity of the resource utilization with the complexity of the needs of the patient. We need a single point person. We can't remember anything more. We're running busy clinics with, like most of my patients have many, many health conditions on many, many drugs, and I'm very distracted by what the patient needs. I can't worry about how to access services at the same time. So we have the primary care co-design tools here that we've just presented to you. Yes, there's only 2, that's all we need. And that's what we need to embed and integrate into team-based primary care around the world. Thank you.
Thank you very much. Okay. We are perfect timing when it comes to presentation, but so a short time for discussion. I really have a dilemma, but let's ask at least 3 questions, because our chat is full of interesting questions. I have first for Sylvie. Do you think that larger number of interviews would change results?
Yes and no. No, because we collected data until a point of saturation was reached, and we triangulated also between the 3 researchers. So the main teams, I think, won't change for today. Maybe tomorrow or next year there will be some changes. And I think nuance I have to make is at a micro level. There, the teams are defined, but how they manifest will be different. We now see that at the primary care zone of Scheldekracht, for example, prevention, the need for prevention is focused on dental care, but in the primary care zone of Ghent, they want to focus on obesity. So the nuances at the micro level, those we didn't catch yet, but we will work on it co-creatively with those two primary care zones.
Okay, thank you. Next question is for Caroline. And the question is from my Polish team. Poland is 300 square kilometers with 38 million population. How do you cope with healthcare desert areas where there are low density of residents but much less density of GPs?
So you're talking. So you mean the geographical spread? Mm-hmm. So we're lucky in some ways, but the health and hospital districts and the local hospital, the primary health networks or organisations, they're all called different things, but across Queensland we have the geographies link up. So in Queensland we would have 7. That are sort of, you'd have 7 alliances within the one state because that's how they're funded. So it really depends on how your country or your state is cut and diced. So I described an area that's very rural, remote. There's huge distances and that has its own issues. But similarly, like Peter was talking about, we have areas that are very urban but have very high needs, but their geographies with the health and hospital services and the networks also coexist. So it's basically how your systems are organised as to how you set it up. So we chose that just because that's how they're funded and they have similar needs, and it's really about trying to support primary care and keep people out of hospital because they don't need to be there. But to do that, you need to work together to do it. Otherwise, we can't change behaviour.
Thank you. And, Peter, you can pass on to Peter. And here is comment, nice work. I wonder why did you not include pharmacists to your healthcare services?
Because it's legally not allowed in Belgium. So we would like have a pharmacologist in our team to help the GPs for the medication schedules, but momentally it's not allowed.
Okay, simple answer. But would we like to change the law? If law is disturbing improvement, just change the law.
We can try it, yes. We're going to do it.
We sometimes have the same dilemma.
Yes.
Thank you very much. So maybe all of you would like to share your experience, because I would like to do just a short introduction, 10 seconds, because Poland is in the middle of a reform of primary healthcare. We have a long background of ugly value in primary healthcare. We start reform, transition from capitation base to fee-for-service. And maybe you have some advice how to avoid problems, how to tackle barriers.
Yes, in Ontario we have about 5 different payment models, and we've decided to ignore that and move forward with what's important to the patient. What can patients expect from primary care? And how, regardless of your payment model, we're going to get down a big rabbit hole if we go into compensation methods. I don't care how physicians are paid. I think the main thing is how do we work together to get the patients what they need when they need it efficiently.
Thank you very much. And I would like to thank you to Mr. Shiva, who answered the question in the app. So you can check it over there. And I would like to thank you, all of you, for the session. It was really fruitful. and this exchanging experience is really very important to us in building value for system and for a patient. I'm really glad to be here. Thank you very much.